Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. In this fourth episode of Antidepressants, we're going to talk about SSRIs. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. By the 1980s, psychiatry had already spent several decades treating depression with MAOIs and TCAs, and the field needed something safer, more tolerable, and easier to prescribe. That shift arrived in 1987 with the introduction of fluoxetine. Fluoxetine was the first widely successful selective serotonin reuptake inhibitor, or SSRI. Instead of broadly affecting multiple receptor systems like earlier antidepressants, fluoxetine selectively blocked the serotonin transporter. By preventing serotonin reuptake in the presynaptic neuron, serotonin remains longer in the synaptic cleft, enhancing serotonergic signaling across mood-regulating circuits. Fluoxetine is typically started at about 10 to 20 milligrams daily. Most patients respond within a range of 20 to 40 milligrams per day, though some require doses up to 60 milligrams. One distinctive feature of fluoxetine is its long half-life, which produces a gradual self-tapering effect and reduces the likelihood of discontinuation symptoms. Sertraline, introduced in 1991, is one of the most widely prescribed SSRIs. Sertraline inhibits the serotonin transporter and has mild dopamine reuptake effects that may contribute to its clinical profile. Treatment generally begins at 25 to 50 milligrams daily with gradual titration. Effective antidepressant doses typically fall between 50 and 200 milligrams per day. Paroxetine was introduced in 1992. It is a potent SSRI but has mild anticholinergic activity compared with other SSRIs. Treatment usually begins at 10 to 20 milligrams daily, with therapeutic dosing typically ranging between 20 and 50 milligrams per day. Because of its relatively short half-life, paroxetine is associated with a higher likelihood of discontinuation symptoms when stopped abruptly. Also introduced in early 1990s was fluvoxamine, which became widely used in the treatment of obsessive-compulsive disorder. Treatment usually begins around 50 milligrams daily and is gradually titrated. Therapeutic dosing commonly ranges between 100 and 300 milligrams per day. Citalopram was introduced in the United States in 1988. It is often considered one of the more pharmacologically clean SSRIs with relatively few receptor interactions. Treatment generally begins at 10 to 20 milligrams daily, with therapeutic dosing typically between 20 and 40 milligrams per day. A refinement of citalopram appeared in 2002 with the introduction of escitalopram. Escitalopram contains only the active S enantiomer of citalopram, improving serotonin transporter binding efficiency. Clinically, escitalopram is often started at 5 to 10 milligrams daily, with therapeutic doses typically between 10 and 20 milligrams per day. As antidepressant research continued, newer agents were developed that technically belong to the broader serotonin reuptake inhibitor family, but incorporate additional receptor modulation. These medications are sometimes described as serotonin modulators rather than pure SSRIs. One example is vilazodone, approved in 2011. Vilazodone combines serotonin reuptake inhibition with partial agonism at the serotonin 1A receptor. This dual mechanism may influence anxiety symptoms and emotional regulation. Treatment usually begins at 10 milligrams daily, gradually titrated to a typical therapeutic dose of 20 to 40 milligrams per day. Because absorption improves with food, vilazodone is recommended to be taken with meals. Another antidepressant is vortioxetine, approved in 2013. Vortioxetine not only inhibits serotonin reuptake but also modulates multiple serotonin receptors, including antagonism at serotonin 3 and agonism at serotonin 1A receptors. These additional effects may influence cognitive symptoms associated with depression. Treatment usually begins at 10 milligrams daily, with therapeutic dosing typically ranging from 10 to 20 milligrams per day. Despite their improved safety profile, SSRIs still produce predictable side effects. Because serotonin receptors are abundant in the GI tract, nausea and diarrhea are common early in treatment. Increased serotonergic signaling in certain neural circuits can also lead to sexual dysfunction, including decreased libido, delayed orgasm, or anorgasmia. Some patients may experience sleep disturbance, headaches, or mild agitation during the early phases of treatment. Like earlier antidepressants, SSRIs increase serotonin levels rapidly, but clinical improvement typically takes several weeks. This delay reflects downstream neuroadaptive processes involving receptor sensitivity, intracellular signaling pathways, and neural plasticity within mood-regulating networks. Another important clinical consideration is serotonin toxicity. When SSRIs are combined with other serotonergic medications, excessive serotonin activity can produce symptoms such as agitation, tremor, hyperreflexia, and autonomic instability. Even with these considerations, SSRIs remain one of the most influential developments in modern psychopharmacology. They reshape the treatment of depression by making antidepressant therapy safer, more accessible, and more acceptable to patients. Although newer antidepressants continue to emerge, SSRIs remain first-line treatments in many clinical guidelines because of their balance of efficacy, tolerability, and safety. That's it for today. Thank you for watching. And if you found this episode helpful, please share it with your colleagues across disciplines. See you next episode as we talk about SNRIs. Bye!